Many of you probably know of Dr. Rothman. She is really our world-renowned expert in bone health. She trained at Brown, got her MD from Columbia, did her internship at Hopkins, and then came here for her fellowship in endocrinology, diabetes, and metabolism. She's been on faculty since 2006. So she's really, really brilliant about metabolic bone disease and how we as surgeons can work alongside the endocrinology team to treat bone health, particularly bone density and healing. So Dr. Rothman, welcome. Thank you for being here. And the Zoom is yours.
Thank you. Thanks so much for having me. I think I'm just getting old. That sounds like been around here a long time before we were even Zooming. All right. That being said, I should be able to share my screen. So let me make sure I can do that in the right view. Let's see. How's that? Is that good?
Yeah, it looks great. Thanks.
Okay, perfect. All right. Well, thank you so much for inviting me today. As mentioned, I really do enjoy working with all of you. And as I'll outline in the talk, I want to kind of go in two slightly different directions, thinking about the referrals that I get from you all that kind of span the lifespan in different ways. So I don't have any financial disclosures. I will talk about off-label use of some medications, though. So I'd like to talk first about optimizing preoperative evaluation for metabolic bone disease, and then a little bit more about some of the classes that we use, medications that are primarily for osteoporosis, but we can also use them in preoperative and perioperative management. And then I kind of want to pivot towards the younger patient population, because I think that's the other group of referrals that I get from you. And we'll talk a little bit more about energy deficits and athletes. So with that, we'll do two cases. We'll talk about a 73-year-old man with malunion, who's kind of loosely based on a patient I saw of one of yours, and then a 32-year-old female runner with recurrent stress fractures. So again, forgive me I'm not a foot and ankle surgeon, obviously. So these are sort of the loose details of the case. But this was a man that I saw who had undergone a previous tibiotalar fusion about 10 years ago, and then had undergone tibiotalar subtalar fusion in August of 2020, and then a subsequent surgery of May of 21, not here, and then was seen by one of our surgeons for ongoing pain and discomfort in his ankle. And the thought was from our team that he had a solid ankle fusion, but there was concern that there was only partial union of the subtalar joint. And so the question here is kind of from a metabolic bone standpoint, what workup should be done? And as I see the broader question is kind of how do we all work together? Because I kind of envision us, broadly and hopefully maybe more tangibly someday as kind of this big multidisciplinary metabolic bone program, which I think we kind of are, but it's a little bit piecemeal. So how do we kind of see this from a global metabolic bone standpoint? And how do we all kind of put our heads together to help this patient have the outcome that he wants? So this is a pretty neat article that comes from a surgery journal. So I don't know if any of you may have seen it, or you may know Paul Anderson, who I've certainly heard at a lot of our bone talks, who's a surgeon who has a lot of interest in perioperative management and kind of, bone health. So this came out of the group at Wisconsin. I'm going to refer back to this a couple times because they actually propose an algorithm. And I think it would be neat at the end if we could kind of talk about that. I don't know that we want to exactly use their algorithm, but I think it's a really good stepping stone to talk about how do you think about bone health optimization in orthopedic surgery, and what could we do here to maybe streamline things. Our waits are long, our access is rough, all those things, and kind of how do we think about streamlining this. So with that as a background, a lot of this is focused on spinal surgery, but I think you certainly can extrapolate it to other surgeries. But a lot of the literature is based on spine, and that's because we know that complications after spinal surgery are more common in patients with osteoporosis. They're more likely to require a revision after fusion, longer hospital times. And the osteoporosis itself has been associated with delayed union and concerns about screw pullout and proximal junctional kyphosis. So what this group did is they did a retrospective study of 124 patients who were candidates for arthroplasty or spine surgery. And these were older patients. Mean age of 69, 56% with prior fracture, 83% female, mainly white. And they looked at kind of what their bone health parameters were pre-operatively. Now, again, these are people they were thinking about this. So you have to kind of take that in your lens, but there was osteoporosis in about half of the women, but in about 20% of the men. And I think that's important to think about because classically osteoporosis in men can be ignored. And we might not think about it so much like in the 70-plus-year-old man that I presented. We don't necessarily jump to thinking that those folks have osteoporosis. And overall, when you included, osteopenia and low bone mass, only 3% of the women and 10% of men were considered to have completely normal bone density. And we'll talk about kind of different thresholds for treatment, but they basically, a lot of them did meet the thresholds for treatment. So why is this not advancing? Here we go. Okay, so I'm going to show you their algorithm's kind of long, so I'm just going to kind of break it apart piece by piece and walk through a little bit and some of the thoughts behind it. So the initial part, again, these are patients seeing surgeons, surgeon assessment of bone quality. And I'd be curious kind of how you all think about that when you're seeing patients and thinking about their bone quality. But they talk about taking into account history, historic height loss, if someone's had a fracture. And then they talk here about reviewing bone density and CT for Hounsfield units. And I'll explain more about what that is. Although I think they kind of jumped the gun a little bit here because I'm guessing I know that not all of your patients have had bone density. They recommend some basics, calcium and vitamin D. And I think here the gestalt is if you think early on that they have good bone quality, then you're going to go ahead and proceed. And then we're going to spend some time on this side of the algorithm now. So they're saying if you're concerned about bone quality, then you consider a bone density, and we'll talk about trabecular bone score and some of these things. And again, if they're normal, you're going to proceed with surgery. So we're going to kind of concentrate on this half of the algorithm when you're thinking that there's poor bone quality and your data demonstrates that there is. So if that's abnormal, talking about getting some basic labs, and a lot of this is what we get. Sometimes we do slightly more extensive workup, depending. Looking at the bone density, thinking about their FRAX score, I'll explain what that is, and just really kind of getting this more complete picture of bone health. I think that's kind of there's a bunch of different things in here, but I would say this is often, I think, when you all refer to me potentially, to us in the bone clinic, when you kind of have that sense like, I'm a little worried. Sometimes that happens preoperatively, sometimes that happens postoperatively. So what do we do in that case? So what are those recommendations for calcium and vitamin D? These are the Institute of Medicine recommendations, which, from a vitamin D standpoint, I'll tell you are more controversial. The calcium's not super controversial. So again, most of these patients, you're going to be recommending between 1,200 and 2,000 of calcium. We generally try to have people get that through the diet if possible, but if not, then supplement up to that point. There's some data that more than 2,000 milligrams of calcium can be harmful and potentially be associated with coronary calcifications and stuff. So it's not a more is better kind of thing. With vitamin D, we do still target guidelines of 30 to 50. That doesn't appear in that paper. And generally, yes, around 2,000 to 5,000 a day is going to get people to where they need to be. And I know I've certainly seen in patients of yours, that you all definitely start supplementing calcium and vitamin D. These are threshold vitamins. So again, more is not necessarily better. If someone's levels are sufficient, you're not going to really improve their bone quality by adding more. And sometimes I'll see, again, patients of yours where they're like, oh, I'm having this non-union, I'm having whatever. And so I just doubled up on my calcium and vitamin D. Again, if you're at that threshold, more is really probably not better. So what kind of workup should be done? This is a general osteoporosis workup. I just want to hit on a couple of things. I don't think all of your patients necessarily need all of these things, but again, serum calcium, we're thinking about, issues with hypocalcemia, the albumin adjusted for that. Serum phosphorus is one we do get that I think isn't necessarily on people's radar if we're worried about poor healing from osteomalacia or some other issue. I'm going to circle back to alkaline phosphatase because I do think that's actually important in some of the patients that you're seeing. Creatinine, vitamin D, 24-hour urine calcium, we do a fair amount here, and a CBC. So, truly, this is basically a CBC, a CMP, a vitamin D, and a phosphorus. So it's not really an extensive workup. There is a more extensive workup that we do when we start thinking about, myeloma for compression fractures, or we'll check testosterone, and we'll talk more about sex steroids when we talk about the younger patients. But this is kind of a basic workup. I just want to highlight this ALK-Phos. I don't know if this has come into your literature, But there is a disease called hypophosphatasia, initially thought to be very rare, but actually really now becoming more easily discovered with genetic testing. These patients often present with recurrent metatarsal stress fractures as adults. So I would like you all to have that on your radar. If you're seeing recurrent metatarsal stress fractures and kind of no good reason, we tend to ignore low alk phos. We kind of get more excited about high alk phos, right? Because we're worried about, bone mets and Paget's and other things. But don't forget the low alk phos. That may actually sometimes be a clue if someone's having recurrent stress fractures. So that may be important for you. Okay, so back to our guy. We did all the things. He's not on steroids, medications that adversely affect bone health. He did smoke previously, not currently. 5 alcohol drinks a week is considered fine from our standpoint. He doesn't have a history of fractures, but he does have a family history of osteoporosis, and his mom broke her hip. So to me, if I was kind of getting that history, I'd be like, I'd probably want to go a little bit further preoperatively if possible. And again, we're seeing this guy postoperatively, but let's just say. So he's got a normal CMP. His vitamin D is low. So I would supplement this. I would probably do it with 2,000 to 5,000 daily of D3. But that would certainly be something I would want to get going as soon as we could. And then we do a bone density, and he does have osteoporosis based on his lowest T-score. So then we'll come back to treatment later on. So what should be done for an upcoming surgery? So as I said, there's been some interest in the orthopedic journals on this. This is actually from the ISCD, which is actually like the DEXA group. So they actually, and again, they came out with a position statement with a group of, metabolic bone folks and surgeons. So really kind of a multidisciplinary group. And the idea was kind of to give you some sense of, who should you be thinking about doing bone density testing on? And these were the groups that they came up with. So people with long-standing diabetes, we know that those folks have low, poor bone quality, and we don't always necessarily think about it or capture it because we don't think about getting bone densities. People may have higher BMIs, but this is a group you should think about, and that may be people that you're, planning surgeries on. Inflammatory arthritis, long-term glucocorticoid treatment. I know you all think about a low trauma fracture after the age of 50, CKD, limited mobility, and smoking. So these are the folks they would say, just kind of have your radar out, thinking about preoperatively. And again, they kind of like the group that I showed you from Wisconsin. They talk about if you actually, again, sometimes this happens retrospectively, right? You didn't know this preoperatively, but then during during surgery or afterwards, I'll get a call from one of you like, we really thought the bones were soft. And we take that very seriously. I mean, you're in there, looking at the bones. You're doing better than I can do with any kind of non-invasive test. So, when you all call us and say, we think the bone was soft, we definitely, we take that very seriously. So we tend to try to jump on that. I'm going to talk a little bit later about opportunistic CT. This is kind of another new thing, a new way of trying to get at that notion of bone quality. As non-surgeons, we're always trying to figure out how can we non-invasively, look at bone quality. And there's some new measures that I'll tell you about looking at Hounsfield units, and it's called an opportunistic CT because the idea is you can actually go back and look at a CT that a patient already had and actually not have to order any new tests. And you can actually look at the Hounsfield units, and that actually supports that they might have osteoporosis or poor bone quality. So, okay, what are our tools for diagnosis? So I'm going to just talk about bone density, opportunistic CT, and trabecular bone score. So this is bone density. This is familiar to all of you. We give patients a T-score. These would be considered in the osteopenia range. And we do also look at Z-score, which is comparing people to other people their age. This is particularly important on the younger people, but I do look at on the older folks too, because even if you're 60, but you're way lower than other people your age, that's probably a signal that there's something wrong. And again, we diagnose normal bone density as a T-score above 1, osteopenia minus 1.1 to minus 2.5, and minus 2.5 and below is considered osteoporosis. So that's generally a quick screening test, easy to do. It's not covered for men under Medicare. So that's also some of why we have to sometimes finagle things to try to get coverage for basic bone density testing. So although, as I said, DEXA is our gold standard for diagnosis and follow-up, it's really not detecting the depth of bone. So it's really considered an aerial bone density. It's grams per centimeter squared. It's really not a volumetric bone density. in grams per centimeter cubed. So the idea is how else can we evaluate bone quality before surgery or, at other times in practice? So one is a trabecular bone score. And I think I'm going to reference the late mentor of mine, Dr. Elliot Schwartz, a little bit here, because I think he actually did talk about trabecular bone score pretty early on to you all, and I'll actually have one of his slides that we'll talk about as a reminder. So at that time, trabecular bone score was just kind of getting started, and now it's really actually taken off, and we have it on our software here. We can actually now bill for it, which is kind of new. We were just kind of doing it, when we thought we wanted that other, like we would just kind of add it on if we're like, bone density seems pretty good. Maybe there's other measures we can get of bone quality. So what is trabecular bone score? So the idea is that, again, this is looking at the spine, but probably, again, extrapolates across to other sites. The idea is that we can use our X-ray projections, but actually get a little bit more information about the structure of the bone. So the idea is that you can look at the amplitude of the rays there and actually get a sense of whether someone has like a well, a good quality bone with lots of good trabeculae, or there's kind of, a bunch of holes in there. And we can actually run this software retrospectively on a bone density that someone's already had. So this, again, started coming out a few years ago, but is really kind of, I would say, going into clinical. At the time we talked about it, we maybe weren't using it clinically, but now we really are. So it can actually, someone can have the same bone density, but actually have a different trabecular bone score. So it's actually really quite helpful for that. So the idea is that if it looks like the first one that I showed you, nice architecture, you're going to get this nice, good score. And if someone's got, unfortunately, poor bone architecture, you're going to get a lower number. And these have now been validated across many cohorts. So the nice thing about it is it's not affected by arthritis in the spine. So you can use it even if we can't use all of the, sometimes we end up excluding the spine a fair amount in bone density. It's actually been associated with fracture risk in postmenopausal women and men over 50. So it's really now been validated on its own. The other populations where we tend to use it are places where bone density just doesn't seem to tell us the whole story. So primary hyperparathyroidism, steroids is classic. People on steroids fracture at a much higher rate than you would expect based on their bone density. So that bone quality is just poor, and you can see that decline in bone quality before you even see a change in bone density. CKD, renal transplant, and diabetes, again, is the other big one. And as I mentioned, that's the population. I think if you're seeing an older patient who's going to undergo a procedure, and again, particularly in men with longstanding diabetes, again, you wouldn't necessarily think about it, but that's one of the populations I would really urge you to think about their bone quality preoperatively, because it's definitely been associated with poor bone quality in the setting of a decent looking bone density. As mentioned, there's no additional radiation to the patient. If they've had a bone density here, we can add it on retrospectively. They don't have this software at Cherry Creek or at Highlands Ranch. Just so you know, on the DEXA right now, they work independently of us. So I don't know if they're looking at getting it. I think it would be great if they were. I know a lot of you are down at Highlands Ranch. We don't really use it for monitoring yet, but that's the other thing that's, I would say, is now being looked at, particularly with our anabolic therapies, like our PTH analogs that I'll talk about. Can you monitor this over time and see the change in bone quality, which is neat clinically, and then also just nice from a patient standpoint, particularly for some of our patients that we're asking to take daily injections for long periods of time to know that they're really working. So that's trabecular bone score. As I mentioned, it's available. I'll circle back to the athletes a little bit later. What's this opportunistic CT? So the idea here is that you can get Hounsfield units off, they've looked at different vertebrae, and this is looking at L1. And the idea is that you can, basically get that sense of bone quality by looking at the trabecular bone and the attenuation on CT. So there's been a lot of studies that I won't go into, kind of looking at what's that optimal number at which you're worried. And the upshot is, there's different thresholds, right? So if you set it higher or lower, it's going to be a little more or less sensitive. Do you want to falsely have more people that you call low bone quality that aren't, or, do you want to capture them all, but maybe some of them are okay? And basically they're kind of settling on these units, somewhere around 110, 100. And then a lot of the way that they validated this is they took a whole bunch of people, looked at their L1 CT attenuation Hounsfield units, and then compared it with their bone density, and are kind of trying to get that sense. So obviously, depending exactly where you set the target is going to be a little bit different. I would say we haven't really used this clinically yet. It's kind of a newer thing, but it's certainly interesting, and I think it makes sense. And if you all have spine CTs on your patients, certainly something to think about if they can kind of go back and look at that. So, all right. So that's our imaging. So getting back to kind of our algorithm here. So we're going to image with those modalities. We're going to get a sense of that bone quality. And then if it's low, then we're going to think about treatment. So how do we think about treatment is going to be kind of my next little section here. So referral for fall prevention, again, I think that more of a me thing than a you thing. But again, I think you're looking at the patient more with a preoperative lens, but that's certainly something we think about. Continue calcium, vitamin D, optimize nutrition and medications. And then here they get into kind of pharmaceutical treatment if indicated. And this is, again, where I really am going to want your feedback. So when do we think about delaying surgery? I think here they're saying, ideally, if you're going to start someone on a medication for poor bone quality, would you delay the surgery? We throw around 3 months all the time, 6 months. I don't know that anyone knows, but we talk about that with the spine folks a lot. Sometimes we're limited, honestly, by how long we can get the medications for if they're not covered by insurance. But this idea of kind of surgical delay, and then the algorithm kind of circles back to the top there that I showed you. So I'd like to talk a little bit more about your thoughts on that in the Q&A. So let's go to our medication classes. So you all think more about the anabolic medications. We do have the anabolic and the anti-resorptive, medications for osteoporosis. So how do they work? Again, this is sort of a blunt, explanation. But as you all know, the osteoclasts are coming in there, chopping out the old bone, and then the osteoblasts are going to come in and fill a new bone. And that cycle is going on in the skeleton all the time. Our medications work a little bit differently. So we have our PTH analogs, teriparatide or Forteo, abaloparatide or Tymlos, and they really work very directly on creating more osteoblasts, which is why they're of such interest, I think, in this population. We have a new-ish anabolic that you may or may not be familiar with. It's called romosozumab or Avinity. It acts on a hormone called sclerostin that's also in this osteoblast pathway. So it's actually a very potent anabolic. It also has a little bit of anti-resorptive. So from a bone improvement standpoint, it's actually a very potent agent. It hasn't really been looked at much yet in this whole kind of like fracture healing perioperative, but I did find one case report when I was reviewing for this of a humeral non-union where they had actually used romosozumab for a year. So, I mean, it's only been approved since 2019. So again, it's a new kid on the block, but I think could be of interest, but not quite as that same sort of, potent anabolic as the teriparatide and the abaloparatide. Then we have our anti-resorptives. You're familiar with the bisphosphonates. Estrogen and sex steroids are also considered anti-resorptive. They stop osteoclasts from working. And then rank ligand inhibitor is Prolia or denosumab. That's also an anti-resorptive that you may have seen in some of our patients. So that's kind of where they sit in terms of bone formation and bone resorption. This is really just for your reference. It's just the way we think about these medications. When we're thinking about patients at very high risk, that's when we're starting to consider an anabolic. And I just point this out because I think just from a practical standpoint, sometimes we really can't get insurance coverage for anabolics on some of the patients that you send us because they don't necessarily meet these criteria. So this is kind of what insurance is looking at when we're trying to get anabolics covered. So if someone's not osteoporotic, hasn't had multiple fractures, isn't considered at high risk for fracture, we're going to have a hard time getting those medications covered. Just so you kind of have a sense of where these medications sit in the osteoporosis world. just a little bit more about them. Again, this is kind of just more for your reference. This is kind of which medications fall in which class. Again, most of our anti-resorptives, these are kind of general oral anti-resorptives, alendronate Fosamax, Actonel. IV zoledronic acid is a once-a-year infusion that we use for osteoporosis. Again, our anabolics, I do want to point out cost is an issue. There is now a biosimilar teriparatide, but the price didn't change at all. So if someone were to try to pay out of pocket for these medications, it can be like several $1,000s a month. And if you're thinking about, for osteoporosis, we think about an 18 to 24 month course. So we can do samples for a few months, but I think, that kind of gets back into this question that I'd love to talk about more of, how long do we treat? How do we think about that in the sort of perioperative, postoperative period? So again, more just kind of for your reference, what are the contraindications? When you send me folks, what am I thinking about if they're a good candidate? The advantage of the bisphosphonates, they're widely available, they're low cost, they can be taken oral, daily, weekly, monthly. The IV, we actually really like a lot from an osteoporosis standpoint because it's kind of just, it's one and done for a long time. And I'll go through this, but the data really don't support that they affect fracture healing. I know that's, you all worry about that from a surgical standpoint. The once a year is great. Patients really like that because once a year and you're done. That the oral bisphosphonates are kind of a shift. Like you have to take it standing up. You can't sit down for 30 minutes, lay down, and You like big glass of water. Can't take your medicines at the same time. Can't eat. So doing a once yearly bisphosphonate is really nice. They do have a few more side effects up front, but then people are generally, I'm sorry about the beeping, but good for the year. Rarely, these have been associated with some side effects such as the atypical femoral fractures, the stress fractures of the thigh, and osteonecrosis of the jaw. Prolia is a little bit different. It's given every 6 months. It's on when it's on, it's off when it's off. So you really can't stop it abruptly, I would say is kind of our biggest clinical problem with it. Because it is an anti-resorptive, all the anti-resorptives are associated with osteonecrosis of the jaw and atypical femoral fractures. So it does, I think it really is an anti-resorptive effect, not a bisphosphonate effect. Teriparatide and abaloparatide, again, I think these are the ones that you're often thinking about. When we're using them for osteoporosis, we're often treating for 18 to 24 months. I did put here or longer. There used to be a black box warning that you could only use these medications for 24 months in a lifetime. And it was because of this initial concern for osteosarcoma. That black box warning has been lifted. So they really haven't seen the osteosarcoma concern that they saw in rats. When the drugs were initially studied, the rat data showed concern for osteosarcoma. And it was young rats, it was juvenile rats. So the concern has been given these medications to anyone with unfused epiphyses, history of radiation, young people, anyone who might be at higher risk of osteosarcoma baseline. I do highlight the unfused epiphyses because, again, I think if you're really thinking about a younger patient under 25, the clavicles aren't necessarily always fully fused until age 25. If it is some of your younger athletes with, low bone density and amenorrhea, sometimes they're a little bit delayed in their puberty. So just, I don't use these medications without, kind of really looking particularly in that population. Although I'll show you that they are starting to be looked at in younger and younger people. Romosozumab, Avinity, I mentioned, again, that's our new kid on the block. Because it does have some anti-resorptive property, it is also associated with atypical femoral fracture and osteonecrosis of the jaw. Its black box warning, however, is for cardiovascular disease. They did see a higher incidence of stroke and myocardial infarction in one of the studies, and that did earn it that black box warning. So they've all kind of got their things. So it's a discussion, but that's kind of what we have right now. So in our patients with severe osteoporosis, we know that the PTH analogs are more effective at reducing vertebral fractures, and we know they work more quickly. And I think that's also what's attractive about them from a surgical standpoint. There are definitely data that teriparatide can improve time to fusion in patients with osteoporosis who are undergoing spine surgery. There's mixed results on fracture healing. I mean, I know we all think about it, we all talk about it, but if you really do delve into the literature, it's mixed. I would say, it certainly doesn't seem to harm fracture healing. And I think that's why we ultimately often end up trying it, because we're in a situation where we want to give everyone every shot, no pun intended, at healing. But the data aren't super robust. And I don't know, I'll show you one upcoming trial, but I don't know that, we're ever going to have really great randomized controlled trial data on this subject, honestly. It has been a couple of meta-analyses, I put them there in the references for you. And even the ones that don't necessarily show improved fracture healing, there are often improvements in functional outcomes by surveys, improved pain scores. And again, there certainly doesn't seem to be anything bad. I mean, obviously we monitor for the usual things. We monitor for hypercalcemia, but they certainly don't seem to be harmful. I would say the cost is probably, one of the biggest barriers. There have been, again, there's a lot of this literature is in the spine, and there have been some, kind of head-to-head comparisons with bisphosphonates, and they may be superior there, particularly when they've looked at things like screw loosening and pull out to the bisphosphonates. That being said, the bisphosphonates really don't seem to delay healing, and that's both in the fusion literature, in the hip fracture literature. There was a big study of hip fractures where they gave IV zoledronic acid pretty quickly after fracture. I think, I've talked with some of you about that in kind of our fracture liaison hip fracture protocol world. But when they looked retrospectively at those patients who had poor healing, in the trial, the ones who got the zoledronic acid actually really didn't have any higher incidence of delayed healing than the only thing that actually panned out in that trial was NSAID use. The bisphosphonates didn't seem to, and I'm referring to a trial of osteoporosis in men with hip fracture, and in older patients with hip fracture that included men. So again, my personal opinion is I think we just need to look at this on a case-by-case basis and, look at the patient who's in front of you. Are there concerns about starting the medication? Does it seem like it could be worth a try? And, that's when we talk and decide what to do. So, what about getting back to that algorithm that I showed you? What did they look at, and what did they decide? Because it's kind of like a real world view, if you will, of kind of this surgical medical enterprise. So they actually found opportunistic CT for 43 of their patients. And they actually saw Hounsfield units of less than 100 in 60% of them. So this is that original 124 older patients that I showed you. They did trabecular bone score in 83 of them, and 34% of them were thought to have degraded architecture, 30% partially degraded, and 36% were normal. So what kind of was the outcome of the 124 patients? They ended up giving anabolic therapy to 45%, some with abaloparatide, some with teriparatide, and anti-resorptive therapy to 30%. So about 75% of them underwent treatment preoperatively. So I think it's just kind of a nice real world example of a medical surgical group trying to figure this out, and trying to figure out which patients need treatment. So about 75% of them ultimately underwent treatment. Okay, so I'm going to switch gears to case 2. I don't know, does anyone have any burning questions? It's always that Zoom thing where you're like, never sure if I know you're all out there, but if anyone has any burning questions. I don't see anything in the chat because I'm going to shift to the younger patients. So I don't know if anyone has any specific, more older patient questions. Yeah,
Michael, this is great. I was going to ask a question which you can defer to later if you're going to cover it, but I'm curious about the Avinity. Like, I'd not heard a lot about it. Is that sort of, as the new kid on the block, do you feel like that's going to become the, like, sort of eclipse the teriparatide, or
no,
too early?
Yeah, it's a great question. It's I think there's interest for sure, and like I said, I just saw this first case report. I still feel like when I go to meetings and people talk about healing and those kinds of things, they still really do focus on the PTH analogs. And the PTH analogs are interesting because they increase bone formation, but they also increase bone resorption. Like if you look at markers, they're in kind of a high turnover state. And I don't know if that's better for healing versus for osteoporosis. I mean, I think we'll see. But I think it's certainly, it's certainly an anabolic agent, and from a pure bone density standpoint, the scores go way up. I mean, I've had a couple patients on it now for a year, and they do well. I mean, the black box warning kind of scares people, reasonably so, but they don't really seem to have the same amount of side effects as the patients on the PTH analogs do. And because it's given at the infusion center, it's covered by Part B. So insurance coverage can be a lot easier for it. So I don't know that I've had any patients with any of you all on it, but it is something we've kind of talked about more with the spine folks. Like, look, we can get this one covered and it's an anabolic. Maybe we should try it, but I don't have a ton of experience with it yet.
So I have a very simple question. This is Mark Myerson. On a practical level, I remember prescribing vitamin D, but it would seem now that on its own, it has significantly diminished value unless you're prescribing calcium simultaneously.
I mean, it depends on how much calcium they're getting, you know? I mean, if they're getting enough calcium in their diet, you know, the vitamin D will help them absorb that. But that's, I mean, the gold standard for figuring that out is the urinary calcium. So we do make a lot of patients do a 24-hour urine calcium, because if their urinary calcium excretion is low, then we know they're not getting enough either calcium or vitamin D or both. So it kind of depends. I mean, and you can kind of get the sense from people and their diet, you know, if they're, you know, I mean, I'll patient be like, oh yeah, you know, I have milk and cheese and yogurt every single day, and a protein shake that has a fortified this and that. And then there's people who like, you know, just are really not getting it in their diet.
Okay.
Dr. Rothman, this is Dan Moon. Just a quick question, not to derail your cases, but
No.
just in terms of a simple question, if it were not for insurance coverage issues, and let's say cost wasn't an issue, do you foresee a persistent role for the bisphosphonates in the future? Or is really anabolic where we're going to head? It's just a matter of cost restrictions right now being prohibitive.
Yeah, it's a fair question. I mean, we don't really have the data. I mean, I like them too. I mean, it makes the most sense, right? But I mean, if I'm going to be purely, and of course, you know, we do try to get them, you know, as you know, but you know, we don't have, from a purely fracture healing standpoint, I don't know that if we're not it depends, what are we trying to do? I mean, are we actually improving healing times? Again, I guess it just depends on the situation. I think there will be certain situations where, like, yeah, I mean, clearly osteoporotic patients, if you can get them on an anabolic, I mean, if I can get an osteoporosis patient on an anabolic before a spine surgery with all the hardware and all of that, yes. You know, for some of those younger athletes with the stress fractures, like, you know, I don't know. So I think it just depends on the patient population.
Thank you.
Okay. All right. So with that, we're going to kind of shift gears over to a younger patient, who, again, you know, these are the patients that you see, the runners, the dancers, et cetera, that have these issues. So this is a 32-year-old runner with a femoral neck stress fracture. She's always had irregular cycles and most recently none. She's always been petite with a low body weight. Recently increased her training with hopes of completing a marathon, and had recently increased her mileage to about 40 miles per week. Denies food restricting, but is vegan. So getting to your point, you know, what's exactly going on in the diet here. So again, you know, in my world, I have the luxury of, you know, I will do the full history of her amenorrhea and her cycles and her calcium intake and all of those things too. But for the purposes of this talk, we'll kind of jump the gun a little bit and go to imaging. So this question always comes up, is what athletes do you actually even think about screening bone density with? Because these are young people. These are not people you're going to normally get a bone density. So, you know, a different group than that first group that I showed you. So a female athlete with amenorrhea for more than 6 months, repeated or unexplained fractures out of proportion to activity. And again, that's kind of a clinical call. You know, certainly, again, you know, we can see abnormal stress on a normal bone create a stress fracture in someone who's suddenly ramped up their training. But if you're kind of getting the notion, you know, I get a lot of these patients from Dr. St. Fard, you know, she's kind of getting the notion like, you shouldn't have really had this fracture, then that's when we'll tend to get a bone density. Because again, bone density in weight-bearing athletes should be higher than non-athletes. And I mean, that sounds sort of obvious, but I think there's this expectation out there that like all runners have low bone density because we think of people like this. But like running is great for your bones, you know, and we can probably have some triathletes and swimmers in the group. But you know, I'll show you some older data that, you know, runners really do, again, if they're eating and they're fueling, should have higher bone density than swimmers and cyclists. And the cyclist literature is actually pretty interesting, but maybe a topic for a different day. So we do consider z-scores of less than -1 abnormal in athletes. Now, -2 is technically considered low in a young person. But if someone is a runner, I would expect their z-scores to be really pretty close to normal or above average. I mean, again, you know, we're still talking less than -1. So they do say that low z-scores in combination with stress fractures do warrant investigation and follow-up, and I agree with that. So this is, again, some old data, but really shows you that, you know, bone density in runners should be good. So this was a study of runners versus cyclists versus triathletes, and I just kind of like it because it just shows you that, again, you know, running is good for your bones. You know, less weight-bearing exercise, you know, not so much. Okay, so she did get a bone density, and she did have markedly low z-scores in the lumbar spine. And this bone density pattern that I'm showing you here is kind of classic for this population. So particularly low in the spine where we see estrogen, and then, you know, maybe less affected in the hips, maybe by some of that loading. So, this is actually a study from Dr. Schwartz, and I believe some of you knew him. He was a nephrologist who worked in California and worked with tons of athletes, tons of elite athletes, and really published and saw a lot of athletes. And unfortunately, died really quite abruptly after a very short illness about a year ago. But he showed this abstract at one of the bone meetings a couple of years ago, and it was very striking because this was one of the athletes he was taking care of, who you can see is a big guy, you know, so 6'3", 212 pound man with really good looking bone density, right? Like all the z-scores are above. And I don't remember exactly the clinical story, but, you know, it's clearly someone who had come to him with repeated fractures or poorly healing fractures or something like that. And the TBS was quite low. So, you know, the TBS can really be an interesting thing in athletes. And I am trying to look at it a little bit more to, again, just give you that sense of that bone quality that maybe we're just not seeing because, you know, big people can have big bones and it can kind of hide things. I mean, DEX is a pretty gross measure of bone quality, or it's not even a measure of bone quality. So getting back to the athletes, I thought Dr. Metzel might like this slide. So thinking about, this is a study of dancers actually with exercise and looking at what's kind of the problem. Like, is the problem the exercise or is the problem the amenorrhea? And again, it's an older study, but I think it really still holds true. So this was 111 subjects, and they looked at dancers and non-dancers, and they looked at dancers who got their periods, again, you know, spontaneously, and those who didn't. Average age of menarche was 14. So again, they're a little on the late bloomer side. So just something to think about. They saw 18 stress fractures, you know, in that population. They were associated with low spine bone density. But interestingly, in the slide I'm going to show you next, the amenorrhea was the key, not so much the dancing. So they compared them to a group of controls. So you'll see here on the bottom, so this is spine bone density, lower is bad. So if you look here, these are the groups, these are the controls not getting their periods. So they're kind of like the worst off, right? So they're not exercising and amenorrheic. These are the dancers who aren't getting their periods. But again, the getting their period group had a higher bone density than the not. So it's really the, it's the amenorrhea. It's not that you can't run. It's not that you can't dance. You just really have to be able to be fueling adequately. And again, if they got their cycles back, they actually had a really robust increase in bone density. So at 24 months, again, these are young people who were not even at peak bone mass yet necessarily. So they can really gain, the older patients don't necessarily gain like this. But those who had the ongoing amenorrhea stayed pretty flat. But if they were able to resume their cycles, they really gained. And I stress this with patients because I think we'll talk about pharmacologic measures, but it's not just the sex steroids that are at bay here. There's just so much else going on in terms of, restriction and red S that we'll talk about a little bit, that, it's worth kind of trying to drive that home to the patients if possible. So again, I'm just going to be real kind of brief on this, but, this whole notion of like the female athlete triad, I think is kind of a little bit going by the wayside, although there's definitely some controversies. But the 2014 IOC consensus paper was really one of the first big papers that kind of tried to take this notion that like it's more than a triad and it's more than females. And I think you all see that. And I certainly see that here, where we are in Colorado, we see a ton of elite male athletes that are maybe not fueling properly. So again, the triad kind of lives here, but their point is that there's really just a lot more going on with energy deficiency. And it's really hitting across multiple places, not just the bone and, not just the periods. So as far as putting people on estrogen, the data on oral contraceptives is pretty mixed, and we tend to not necessarily use them for this purpose. I won't get too much into the nitty gritty of the hormone side of things, but there's concerns that oral estrogen might suppress IGF-1, maybe suppressing testosterone. I mean, we know it suppresses testosterone because we use it for that purpose in other settings. But it's really not necessarily the best choice for people with hypothalamic amenorrhea. So the recommendations are patch estradiol with progesterone. I took out for the purposes of time a different study looking specifically at amenorrheic athletes or oligomenorrheic athletes that actually compared patch versus pill, and the patch folks did better from a bone standpoint. I do tell all patients this does not provide contraceptives. So we're really giving a low dose kind of physiologic estrogen. The estrogen itself does not provide contraception the way a birth control pill would, but we can actually use it with like a Mirena IUD. It works great. And then someone can have the contraception and also the estrogen back. So when we think about recovery of these things in our athletes, the idea is really if you can, recover energy status. I mean, that's really the most important things. And again, just that, fueling properly, working with our dietitians and all of that also stimulates the anabolic bone formation, stimulates IGF-1. It'll kind of reverse all that. We see thyroid abnormalities. We see all kinds of things where the body's just trying to conserve everything, right? So there's no room for kind of all these other measures. And then recovery of menstrual status we'll see. And then again, it takes a while for the bone density to pick up. When do we think about teriparatide in these folks, right? That's the question that you all often ask me. So this is the study everyone points to. It's a short study, but it's got some interesting data. And this is an endocrine group out of Harvard. And they looked at premenopausal women with lower extremity stress fractures. So, that group that you're seeing, 11 of them, but 6 of them got Forteo, teriparatide, and 5 of them got placebo. And they looked at bone markers and they looked at baseline 4-week and 8-week MRI. And just draw your attention to the right side here. So these are the bone formation markers. So P1NP is essentially what we use as a marker of osteoblast function. So if you're making more osteoblasts, your P1NP is going to go up. And not surprisingly, it went up a lot. We're happy, generally with about like a 10-20% increase. But this went up, robustly. And again, we do see that sometimes in young people. The CTX also goes up. As I mentioned, when you put someone on a PTH agent, both bone formation and resorption go up. And again, of course, in the placebo group, it didn't. And they really stress this part that, maybe you're really seeing, this is what we call the anabolic window of bone formation, right? Like you're really seeing an increase in bone formation. And the study was nice because I liked this graph here, or this table on your left here, because they actually showed the differences in healing in each of the individual patients. And you can see there's variability. And I think, we see that clinically in terms of people who really seem like they got a lot better in 8 weeks, people who really didn't get better at all in both groups. But they did seem to do better if they got the teriparatide. Again, small study, but 83% of the teriparatide group had improved versus 51% of the placebo group. It was not statistically significant. So, when you ask about, should we absolutely be doing this for everyone? Like, I don't know, right? Okay. But there's a study upcoming that I think is going to be really interesting that we should all keep our eyes out for. So this is just actually the trial. So I think this is going to be really interesting for the patients that you see. So they're actually looking at Army recruits, men and women, 18 to 40, who have lower body stress fractures, and they're giving them teriparatide for 16 weeks, and then maybe extending it to 24 weeks if they're not healed at 16 weeks. And they have a whole bunch of, radiologic outcomes that they'll be looking at. So, stay tuned. I think this could be a good study that will help us answer some of those questions, at least in these younger patients. So lastly, I just want to make a plug. I don't know how many of you are familiar with the orthopedic group Own the Bone. This is again a group from the American Orthopedic Association that's really kind of taken on looking at fracture care, particularly fragility fracture care, and really trying to help with things like fracture liaison services and providing some of that post care. But also just, I think, the fact that a group that's just really taking a good look at metabolic bone disease as a whole, as we're trying to here. So just kind of neat to know that there's surgeons out there, doing this. So that's all I have. I just want to kind of acknowledge all of our different teams. We have our geriatric hip fracture program. We do have our fracture liaison service. We've got our clinicians. We've got our spine folks that we work with closely. And I just did want to give a moment of memorandum to Dr. Schwartz, who I know was a colleague for some of you as well, and greatly missed. So that's all I have.
Yeah, thanks. Thank you, Dr. Rothman. That was really fantastic, comprehensive, and definitely of great interest to us. And I appreciate your acknowledgement of Dr. Schwartz. I think you, as you recall, I believe he came out for that very session that we had back in 2015 or 2016. And he, I worked closely with him when I was in the Bay Area, when I was at Stanford. He was just across the Bay, and we collaborated a lot on athletes, particularly with high risk stress fractures. So he'll be missed for sure. He was definitely a leader, if not the leader in that particular field. So I wanted to open up to questions from the group. Does anyone have anything burning?
Hi, Doc. It's Teresa Alpert. That was fabulous. I'm a woman in my late 60s, so I'm all over osteoporosis, osteopenia, and so forth as it applies to myself. I was curious, what's your sense of using bone stimulation or vibration therapy for bone strength?
Yeah, that's a good question, although I might have to defer that back to you all. I mean, I feel like most of the people that I'm sent to by you all, you are still using those. I don't know. Dr. Hunt, can you elaborate on that? When do you see that coming? I mean, that's not something I prescribe, but I do see a lot of the patients that I'm seeing have them prescribed.
It's a good question. As Teresa asked that question, I was thinking of I did some bone research when I was a medical student, and there was a lot of interest in sort of mechanical, like vibration and such for bone density. It was driven really by NASA, who noted that astronauts would come back and have severe osteoporosis. So it's just a way to maintain bone density while they're in space. I've seen it at the gyms. It's not something that we have a lot of knowledge about. I know that the principles are there, but I don't know that we have like the protocols to guide prescription. But it's interesting. Yeah.
Yeah. I mean, from a pure osteoporosis standpoint, there's this OsteoStrong people may have heard of that, they put people on these vibrating plates and stuff, but not great data for that, but and also some concerns potentially about like fractures. I mean, again, in some of the older, frailer patients that I'm seeing, I'm like, I don't know that you necessarily want to, but you all use them for healing, right? Still, or
well, not really. I mean, I don't know. Does anyone on the call use like the little vibration plates for for healing. I really don't. Like, it's not part of, and part of it is that, they're not easy to access. And part of it is that there's no like prescriptive protocol. And to your point, you don't want to get that patient where you say, go use this thing at the gym, and they go overuse it and develop another problem. So it gets muddy. But it occurs to me that, like, I'm not really sure why. I don't know why that whole technology sort of died in the crossover between application and sort of medical prescribing. But I'd be curious, does anyone use that or familiar with it? With like, I don't even know a brand, but a little vibratory mechanical vibration plate for healing. I have gotten on it at the gym, but that's just because I wanted to see what it did.
Carefully, right?
Yeah.
Hey, it's Josh Metzel. That was a wonderful talk. One of the thoughts that I had in these past few weeks when we've been discussing this pro athlete case together is, do you think there is a role for using something like Forteo plus surgery so that we're maximizing bone healing potential in the context of our surgical procedures? Because really, I think that when I think about these athletes, that's the biggest concern, is that we do surgery and then it doesn't heal. But also there is a downside to waiting in a high level athlete 16 to 24 weeks, like the study you showed with the recruits. So I don't know if you have any thoughts on kind of pre-treating these patients and how long the optimal time frame would be to achieve benefit.
Right. I mean, and it kind of gets back to just like that surgical delay question for other things. I mean, obviously we're not going to really improve someone's bone quality massively in 8 weeks if it's someone with poor bone quality. But could you help a fracture progress, which I think is more, the patients that you're seeing in 8-12 weeks? Probably, right? I mean, just based on that anabolic window data, I mean, there's clearly something happening when we get bone turnover markers, 4-8 weeks into teriparatide, like, I mean, maybe not as robust as that study, but you definitely do see them go up. What that means though, for you in the OR, I don't know. I mean, ideally, when I work with the spine folks, we try to do 3 months pre-op and kind of all the way through until they feel like their fusion has taken, or again, if it's someone with real osteoporosis that I'm going to treat for 18 to 24 months. We're not necessarily going to do that in an athlete, but I don't think we know, but I would say some period of time before, during, and after, especially if there's hardware involved. I don't know if what others do.
Yeah, I mean, I think that what you just outlined makes sense, in terms of like the timing. The duration is really, I mean, as and this was largely driven by Elliot, but there are people that are on Forteo for 18 months. I mean, there's not there doesn't seem to be a strong concern about the length, even like 6 months beyond radiographic healing for those navicular fractures. And we had one of our NBA guys, like most of them, tall center, came in with kind of 2 navicular stress fractures, and we treat him with Forteo, and got Elliot involved, and he said, "Yep, keep treating him even beyond healing." So yeah, it's an unknown, and it's hard to quantify, I think.
Yeah, I mean, there doesn't really seem to be a downside that I can see. I mean, as long as, the bone parameter, I mean, they're not getting hypercalcemic, they can tolerate it, they can afford it, I mean.
And as you pointed out, the sarcoma risk really hasn't materialized from what I've seen in terms of case reports outside of the rodent study. So
right. I mean, I'm still cautious about a history of radiation. I mean, again, this comes up for me more in like my postmenopausal women with breast cancer who've had radiation. I try to avoid it. The very young folks, I think you and I have talked about sometimes before, we've seen like 18-year-olds. I'm not so sure, but there is still for the if they do have a high baseline risk of osteosarcoma, I'd be worried, but not in someone with, adult with fused epiphyses and no history of radiation, et cetera.
Right. But, and you and your team are so thorough about getting the lab tests and identifying those risk fractures and getting x-rays to look at growth plates and everything. So that's why this is an endocrinology, driven medication. It's not something that I'm not going to get the pen out and teach the athlete how to use it. But I think, so we use this routinely in our professional and even collegiate athletes who have sort of the access to pay cash for it. But I realized for our group, when we refer someone to you saying, hey, candidate for Forteo because of, and usually at least in my practice, it's usually, young active person with a non-healing or delayed healing of a high-risk stress fracture or fusion. Like, it's not usually for osteoporosis treatment.
Right.
And so I recognize, as you pointed out, that's an off-label use, but we know it's effective. There's good literature support. What are you doing with those patients we send who don't have the financial means? Are there programs to get it approved through insurance? Are you giving them freebies? Like, how are you managing that? Are you giving them something else?
So we do have samples. So Forteo is actually now so we don't get anything from Lilly anymore, basically. So we have Timlos samples, which is a baloparatide, which technically hasn't been as well studied, but I think it's essentially the same, but for this purpose. But we will give samples. I mean, again, that's all we have. And we don't have the generic teriparatide samples anymore. So we can kind of get into a bind. So we'll try to do at least that 3 months, sort of see how they're doing. I have a patient right now with Jason Stoneback, who's got, one of the limb restoration patients. And we've been going for about 9 months because we're just not there. I mean, so it's a very individual decision. But it's harder, when we're going through our samples, because we don't always have them and all of that. Try to get them to meet if we can. That's the other thing about doing the bone density and stuff too, is like sometimes we can be creative with these new trabecular bone scores and all that. Like we can kind of diagnose osteoporosis different ways, even if their T-score is not so bad.
Yeah. Well, and it occurs to me that we went through the cycle with bisphosphonates where the sort of patent ran out and it became generic. And so that inevitably will happen with teriparatide, I would think. Like, eventually it's going to become affordable.
I don't know. Now the biosimilar is just the same price. So they basically put out the biosimilar, but it's still over $1,000 a month,
That's a hard. All right. Any last minute questions before we let Dr. Rothman go?
Dr. Rothman, this is AD Rosa. I'm a part of the biomechanics lab and an orthotist, also triathlete. So I have a question for you. I want to hear your thoughts on using multi-minerals and also avoid inflammatory foods to improve bone density geared towards improving bone marrow health.
Sorry, that was a little bit broken up.
Yes, I just want to, I don't know if you can hear me. I'm in the car right now, but I want to hear your thoughts on multi-minerals and avoiding inflammatory foods to improve bone health.
Oh, okay. Minerals. I think generally like a broadly, whole food based diet, you can get most of what you need. I'm not a big proponent of like tons of supplements or anything like that. So I think, the patient I mentioned who was vegan, sometimes we do have to supplement things, but for the most part, I think, I know there's controversy about dairy and inflammation, all that. I like dairy. I don't know. I don't know. So I don't tell people like not to eat dairy, but whatever, if people want to get their calcium through goat milk, or that's all fine too. But I think trying to get it through food as much as possible.
All right. Well, thank you again, Dr. Rothman. That was really fantastic. And for everybody, this was recorded, and so it'll be available on our website if you want to go back and review it. Thank you again, Dr. Rothman. Really appreciate your collaboration and your being here this morning.
Thanks.
All right. Have a great day, everyone.
You too.